Good morning, everyone. Welcome to Medical Grand Rounds. We have a very exciting lineup for you today, I'm pleased to say. You might be wondering why I'm doing the introductions. Our impresario, Errol Osdalga, has a very, very good excuse for not being here today. He and his wife, Joanna, are the proud parents of Isaac Cruz Osdalga. So we welcome Isaac, and I know his sister, Aria, welcomes him too. And we wish them all the very best. I'm now going to turn it over to our chair, Bob Harrington, who has a special announcement.
Well, it's hard to top the birth of a baby for one of our faculty members, particularly one of our faculty leaders, Errol, who has been so wonderful over these last 7 months in organizing all of our communication activities. So congratulations to the Osdalga family as it continues to expand. And Errol, we look forward to seeing you back on the screen here when the time is right. No hurry. And Abraham will take care of things in a very capable way. But just as we announced the birth of a new addition to the Stanford family, we thought this would also be an important time to acknowledge the birthday of one of our senior faculty members who has been with us at Stanford for a long time and has been leading our infectious disease epidemiology in the hospital for many years. So please do join me in thanking and congratulating and wishing well. Happy birthday to Dr. Lucy Tompkins. Goopy, I don't know, as the division
Oh my
chief,
goodness.
if you'd like to, Goopy, do you want to chime in?
I had no idea.
Lucy, this is why you're here. I just wanted to say we love you, we honor you, and we're so grateful for your leadership and your role model to so many of us. Happy birthday.
Thank you. You've all been just so wonderful. They sang me a happy birthday on video the other day, and it's been so great. I am so honored to be among the faculty of the Department of Medicine. I truly am. Thank you so much.
We're a better place because you're part of the faculty, Lucy. So thank you for all you do. And again, a happy birthday from, let's see, from 258 of your closest colleagues.
That's so wonderful. Thank you.
Hopefully
Abraham, back to you.
Okay, thank you so much, Bob, and happy birthday, Lucy, echoing everything that was said. So we have some updates to present. Let's begin with, actually, we had updates from Brian Bowman. To Leah, before you go to that. Brian, is Brian here? Actually, I don't see Brian yet, so
I am.
let's
here.
go. Oh, sorry, Brian, there you go.
I just am struggling with my screen share. Sorry about that. I was going to share these data on our experience with our healthcare workers across Stanford Medicine. You can see here. I hope you're all seeing this. It's a different way of presenting it than we used to have in the past. We have a new dashboard. But the important thing is just to see that these numbers that were pretty high back in late July, falling off in early August, and really having a nadir at the end of August, beginning of September, seem to be creeping back up. There are small numbers. The statistics on this probably are not alarming, but the anecdotal aspects of it are somewhat alarming, to me at least. This number at the end is just a partial week, and as you can see, the rolling week new cases of 17 is higher than we've had for several weeks. And this is partly because I can't remember if we mentioned this last week, there was a small cluster of cases in the CVICU at Packard Hospital. 4 employees and 2 patients were infected over the course of the last 10 to 14 days. And it appears that that's not exploding into anything like the Brigham experience, luckily for us. In that the last 150 or so tests that we've done as we've broadened the net to make sure that there's no infection spreading among the folks that have been in the ICU. The last 150 tests have been negative. We have more to do, so we're not completely sure about that yet, but it looks good. But it's just another opportunity to talk about, very briefly, about the common experience that we had talking to friends and reading press reports from Brigham, and just our own experience. it's the same things that are happening that are causing some of these outbreaks. I think it's important that we're all aware of them. It's really things inside the health system, like inconsistent PPE wearing, particularly eye protection, inability or unwillingness to maintain social distance in break rooms and when eating. There are things that happen outside the system, potlucks that folks are going to outside of work together, international travel that's not done terribly carefully, family contacts of COVID that aren't revealed. These are sort of the things that we see under the surface when we have an episode like this and we start to interview folks that have become positive. And so it makes it very muddy. It's unclear whether some of these infections actually are part of a cluster or were community acquired. But the lessons are that we really need to do, the other one I wanted to mention is working with mild symptoms. Folks, if you have allergies and they act up on you, get a COVID test. We've seen this a few times where people are working for some time thinking that it's just allergies, and then they turn positive they are testing positive for COVID. So, you know, we're having a lot of conversations about how do we improve, how do we maintain vigilance, how do we maintain these behaviors. I am in great danger of becoming the Stanford medicine scold about this in my new role. And I don't want that to happen. I think that, you know, I don't like to talk about, well, wear a mask, it's easy. You know, none of this stuff is easy. It's not easy, but we have to do it. And what I'd like to say is that it's on us to make it easier for folks to do the right thing. And I think, you know, there are things we can do in terms of improving break room utilization, better masks and goggles that don't fog up. Another interesting thing is people who order a respiratory panel but don't check for COVID. That's happened at least twice, where that's prolonged exposure in the hospital of a symptomatic patient that we didn't know was COVID. And so we're going to make sure that all respiratory panels include COVID, whether they're ordered that way or not. So we're going to do our best to try to make it easy to do the right thing. But at the same time, I think all of us who are on this call are influential with our colleagues, families, friends, and we need to keep this in mind and really push for continued vigilance against COVID. It's not over yet, as we all know. Thank you.
Thank you so much, Brian. Appreciate that. I'm going to now turn it over to Will Collins from the Hospital Medicine Group to give us an update.
Thanks, Abraham. Piggybacking off of what Brian just said, I was going to, excuse me, clear my throat and then talk quickly about inpatient updates for COVID-19. If my slides will advance. There we go. So this is from the New York Times, and as we were just mentioning, recently case numbers in the United States have gone up. A number of potential theories for this, but at least the death rate has not gone up with those case numbers, at least as of yet. Sorry. Excuse me. So this is now looking, however, at our local area. And again, at least other than for Santa Cruz County, which is the pink line here, a little hard to see in the mess of different lines. But for the most part, our local counties rates are still going down, which is overall good news. This is looking at our COVID positive numbers for the Stanford healthcare system. So the top graph here is new positive cases by week. Again, interestingly, we had this large peak at the middle of July, and then it has come down quite a bit. The bottom graph is looking at new hospitalized per week, which we also see has continued to come down, although it sounds like we should not we should be cautiously optimistic, I guess, with this. Definitely want to make sure that we're staying vigilant. Looking at specific numbers, we this morning had 4 PUIs in the hospital, 10 confirmed positive COVID, of which 4 were in the ICU. Looking at our numbers overall from March 1st to October 4th, this means that our ICU rate is essentially the same, just over 20%. and we're still at 31 deaths for a rate of 6.6%. We continue to have slightly more females than males. The numbers, at least through October 4th, showed no new pediatric admissions, and our age range, again, is fairly broad. So with that, just wanted to thank everyone. Thanks for giving me the chance to provide this brief update.
Okay, great. Thank you both for that update, and we need to continue being vigilant. Tulia, if you would share my PowerPoint one more time. So I want to alert you to something that's going on at Stanford that might be of great interest. The Janssen COVID-19 Ensemble vaccine study is beginning. The PI is Dr. Grant. It's a double-blind placebo-controlled trial, and if you're interested, this is the website. We'll also put it in the chat function so that you can see it there. If you have questions, you can email the team at vaccines_program@stanford.edu. Again, the website is www.ensemblestudy.com. Next slide. I also want to honor Dr. Kelly Skeff. We just discovered that he is receiving the Alumni Excellence in Education Award from the Stanford Graduate School of Education. He's a beloved figure at Stanford. Many of you know him. He helps medical faculty all over the world improve their teaching effectiveness. He and Georgette have this wonderful course that many of us have taken. He's trained over 30,000 faculty and residents. We're enormously proud of him and his accomplishments, both in education. He has a PhD from the Stanford School of Education, as well as in medicine. So congrats to Dr. Skeff. Next slide, please. This is a brief overview of our upcoming grand rounds. On October 14th, we'll be doing a grand rounds on the health effect of wildfires. On October 21st, Dr. Jagannathan will be presenting some of the results of the Lambda trial, Lambda interferon. And then on October 28th, we'll hear from our investigators on immunomodulators for the treatment of COVID-19. Thank you so much, Celia. You can stop sharing. So it's my pleasure now to introduce the speakers for today's grand rounds, and I'm going to introduce them in reverse order. Our first is Shuchi Anand, who is an assistant professor here at Stanford. She had her training at WashU and then her residency training at the Brigham before joining us for her nephrology fellowship and stayed on here. She has been an outstanding clinician and has had a long interest in public health, global health, and became medical director for one of the 2 hemodialysis facilities dedicated to COVID-19 patients early on in the epidemic, a truly important and heroic sort of experience, and is a co-author on the study that you're going to hear about today. Also, she is, I should say she's the first author. She also has a great interest in global health and nephrology health in other countries, in Asia particularly. I'd also like to introduce Maria Montez Rath. She is a biostatistician. She trained at the UMass in Dartmouth and then came to Boston University for a PhD before joining the nephrology section at Stanford, where she's the director of the biostatistics core. She has really had an opportunity to do wonderful work because of access to the United States renal data system. Her particular interest is the epidemiology of renal disease, but also she's an expert on missing data and an important contributor to much of the work that you're going to hear about today. And last but not least, and the person who's going to present first is Julie Parsonnet, professor of medicine. Julie trained at Harvard for her undergraduate degree and Cornell for medicine, residency at MGH, as well as her infectious diseases fellowship, and has been a beloved and longstanding professor here at Stanford. She's best known for her work with H. pylori and its link to gastric cancer, to lymphoma, its epidemiology, but she's had her hands in many different major research efforts, one of which you're going to hear a little more about. So welcome to all of you, and I'll turn it over to you, Julie.
Thank you very much. And let me share my screen. Thank you very much, Abraham, for that lovely introduction. And thanks very much for inviting us here today to present this teamwork. To start today, I'll be talking about seroepidemiology and how it's used in general. And I'll be followed by Dr. Montez Rath, who'll be talking about the methods that we use to do the study that we're presenting today in dialysis patients. And then will be Dr. Anand, Shuchi Anand will finish up discussion today, just talking about the results and where we hope to go with our work on patients receiving dialysis. So simply put, seroepidemiology is the study of antibodies to specific antigens in populations. And we usually use it for the study of infectious diseases, but it could be used for the study of any antigen that you want to look at population distributions. It's been critical in infectious diseases for understanding the distributions of disease, risk factors, and for efficacy of vaccines. They're popular because they're very easy to perform. And they only really need access to population samples of blood. I will point out that one of the first studies done on seroepidemiology of COVID was done here at Stanford by Eran Ben David and his team, which showed for the first time in the United States that we had very low levels of antibody in populations. So seroepidemiology serves a number of purposes, and I'm going to mention them first here. On the left, this is a study that was done in Spain. It was published by Dr. Polan in Lancet a few months ago. And they looked at 60,000 people in Spain, and they talked about the descriptive epidemiology. So here you could just see in the darker colors, they were able to describe which parts of the country were most affected by COVID and which parts of the country were less affected. This is a slide from the CDC's website, where CDC is doing a number of seroepidemiologic studies. This is from their 10-city study, where they're looking at 10 cities repeatedly sampling, and they're looking at remnant sera from laboratories. On the bottom, this is New York City, and on the bottom you could see the peak of seroepidemiology of cases in New York. So you could see the peak of PCR positivity in early April, and then in the middle bar you see the cumulative number of cases in New York City. And the top section is the serology and the serology results. And you could see those 4 different areas where they did it. And you could see the blue is the bottom confidence intervals, and the black is the upper confidence intervals, and the middle is the mean. And what you could see is that antibodies went up quite dramatically from less than 10% to 25 to 27%, somewhere in that range at the end of April. And that they're coming down a little bit. There's more confidence about the range. Maybe they're tailing off a little bit. We don't know whether that's because they're waning or because they're sampling different populations on each occasion. Another use of seroepidemiology is to look for risk factors for disease. So this is a study that was done in England that was recently published in preprint form only by a group at King's College. And they were able to use serology. They sent actually these kits home to people. So people were doing their kits, LFA kits on themselves at home, and then sending the results back. What they found was that if you were involved in healthcare, you had higher rates of antibodies to SARS-CoV2, and it's particularly if you're involved in home-based healthcare. They also found things that we are also finding in the United States, which is that minority groups have higher rates of disease in their population, both Blacks and Asians and mixed populations. And then increased population density, so increased household size, that third bar there, that people who are poorer are more likely to have COVID. And then what, again, I'm going to come back to later in my introduction is people who have mild symptoms will have antibodies to SARS-CoV-2, but they may be lower than you see in people who have severe symptoms. And then this is another use of it. This is a paper that has just been published in Bulletin of the World Health Organization by John Ioannidis here at Stanford. And he was looking at trying to figure out the infection fatality rate. So normally when you just heard us actually talk about, Dr. Bowman talk about the percent of cases who had died at Stanford, that's a case fatality rate. It's the number of people who presented with illness in the denominator and the number of people who died in the numerator. But what's of great interest to people is of everybody who's infected, symptomatic and asymptomatic, what is their mortality rate? What is their fatality rate? So the denominator has to include symptomatic and asymptomatic. and the numerator is number of deaths. So John looked at 82 studies and actually looked at thousands of studies and found 82 that he was able to look at the infection fatality rate. And on the bottom are the various countries, and you can see the infection fatality rate on the left on the y-axis. And what I'd like to point out is in Louisiana is those brown bars. So they've had the highest infection fatality rate of around 1.3% and corrected to higher than that, 1.5%. There is one study in New York where the infection fatality rate is significantly higher, but it's not seen here. And then there are many places like China outside of Wuhan where the infection fatality rate is actually very, very low, and in Japan as well, where the infection fatality rate is low. But we couldn't do these studies without using serology. And finally, we're using serology to look at this, herd immunity. And this is obviously of great interest to so many people to try to figure out when we've reached a point where we can let down our guard and have people go out and open up the economy more broadly. And also we need to know about this because we need to know about vaccine responses and who's likely to respond to vaccines, what populations to target and things such as that. So seroepidemiology is very useful. So there are a lot of serologic tests. We used Siemens test, which is an excellent test of 100% sensitivity and 99.8% specificity. We're going to get back to that later. But they target different antigens. So you can see the virus up there at the top, and the red is the spike protein. And there are some serologies that look at the spike protein and some that just look at the receptor binding domain of the spike protein, the RBD. And then there are other ones that look at the nucleocapsid. So there are all sorts of different, and some look at multiple antigens at once. So there's all sorts of different types of serology tests. Some are done in the lab. This is a picture from Stanford's lab where they're creating the serologic test. And some are done with these lateral flow tests, which are a lot like antigen tests that can be done as point of care. They all are, all the ones that are now available are reviewed by the FDA, and the FDA publishes those results on their website. So if you know somebody who's getting a, if you're using a serologic test and you don't know its performance, you can go to the FDA website and look for their EUA authorized serology test performance, and you can see the sensitivity and specificity. But I will say that all of those always overestimate sensitivity and specificity, so you need to take it with a grain of salt. So there's been a lot of bad press for seroepidemiology and people saying it's not reliable and we shouldn't use it and we don't know what it means. And some of that is true, but overall, I think it's gotten a bum rap. And I'm going to address some of the issues related to problems with seroepidemiology. So first, this is a study that was done by our colleagues up at UCSF, Whitman et al., who in August published an evaluation of many different serologic tests. And each of those rectangles represents a period of time after onset of SARS-CoV2 in patients, after the onset of symptoms of COVID. So the top is within 1 to 5 days of onset of infection, and the bottom is after 20 days after. And the lightness of the bar indicates, and each row, so you can see each of those boxes has rows going across, and each row represents a patient sample. So, and each column represents a test, a commercial test of some sort or another. And the blue ones are LFA tests, the point of care tests, and the pinkish purplish ones are ELISA tests, so that are done in regular laboratories. And what's important to see is at the top, there's a lot of light lines. So in 1 to 5 days, almost all these tests are negative in most people. So they don't work all that well early on, which is completely understandable since we all know that antibodies go up over time. And at the bottom, you can see that most of them are pretty dark. So after 20 days, most of them work. Some of them don't work as well. And it's important when you're thinking about using a test or looking at a study that you understand these characteristics of the test so you can understand them. And that doesn't just include, it includes what kind of test it was, but also whether they're looking at total IgG, total immunoglobulin, IgG, or IgM. So another problem that's come out in the recently is that these antibodies seem to wane. And so this is a study that was recently published in preprint from England. And they looked at serologic responses in people over time. And first, if you look at the colors, you'll see that the people who had the least infection or were asymptomatic are shown here in orange, where the people who had the worst disease are shown in purple and blue. And what is pretty obvious is that people who are asymptomatic or have mild infection are down towards the bottom, and the people who had serious infection are up towards the top. You'll also see that there are 3 different antigens shown here. So there's the spike protein, the RBD is in the middle graph, and the nucleocapsid is at the bottom. And they perform differently. So you need to know what test you're using so you can interpret what these serologies mean over time. And the third thing is that over time, they do seem to wane. So seems to be happening less with the spike protein than it is for the RBD, which is the more specific antigen, but they all do seem to wane a little bit over time. But I will point out that most people who are positive do stay positive. The great majority of people, at least up to 2 or 3 months, stay positive. Their titer may be lower, but it's not that many of them that actually go from positive to negative. It's in contradistinction to people who are asymptomatic, where all bets are off. And the last thing that serology has been given a bum rap about is the predictive power of a positive test. And that isn't a problem with the serologic tests themselves. No serologic test works well when there's no disease. So this is a graph that just shows the relationship between sensitivity and specificity of tests, prevalence, and the predictive power positive. And on the left, at the x-axis, when the prevalence is really low, it doesn't matter whether you have a very sensitive specific test or not. You're never going to have a good test when the prevalence is low. Most tests are better than that top red bar that are available now. Most are above 95% sensitive and specific. So they'll work, and they'll work well when you start getting to 20%, 30% infection, but they will not work well. And that's not a characteristic of the test, it's a characteristic of statistics. So this can be, you can fix this by doing a second test. So if you do one test and it's positive, you do a second test and confirm it, and you can push the predictive power of a positive test up. So when to use serology? I think there is no information yet that you should use it on individuals. We don't know whether it confers immunity, we don't know if it protects you, and we don't know often whether the results are right because we don't know the predictive power in any individual. But on a population level, seroepidemiology is incredibly helpful. It'll help guide vaccines, it'll help us understand where interventions work and where they don't work, and it'll help us just understand risk factors and distributions for disease. So my last slide is really about bias. There are a lot of biases in seroepidemiology studies, and the big bias is who are you studying? Where are these blood samples coming from? Many of the studies so far have come from sick people, meaning people, they're done on remnant serum that are in laboratories. So there are people who have come in for health reasons. And so those are biased. And other samples have been done on healthy people who are responding to a Facebook post or driving by a store or walking into a grocery. And so those are also biased towards the healthy population. And the problem with both of those studies is that we don't know how these populations represent the population at large. We don't know how sick people or healthy people relate to everybody. And so what we really want is a study that represents the entire country and that we can use as a sample for the total US population. And that brings us to our study today, which is really trying to get an unbiased estimate of the seroepidemiology of SARS-CoV-2 in the United States. So with that, I'm going to pass this over to Maria Montez Rath, who's going to present the study design.
Thank you, Julie. Let me share my screen. Good morning, everyone. So I'll be speaking about in detail a little bit about the methods that were used. And we'll start with describing the dialysis population in the US. So there are about 500,000 patients receiving dialysis in the US. And of note, dialysis is covered by Medicare independent of the age of the individual. Patients on dialysis undergo routine monthly laboratory studies to check on the effectiveness of their therapy or to screen for complications. And the vast majority of the individuals on dialysis in the US are on hemodialysis. This means that there is no need for phlebotomy to acquire blood samples, as the blood can be drawn directly from the dialysis machine. So for this study, we partnered with Ascend Clinical Laboratories, which received samples from about 1,300 facilities, dialysis facilities, and serves close to 65 patients monthly. So we calculated that we needed about 27,000 patients to estimate a prevalence of 5%, with a 0.5% absolute precision within a region. We randomly select about 31,500 patients proportionally by zip code, age, sex, and race ethnicity from the list of patients whose samples were processed by Ascend in June. And we oversampled because we were concerned that about 15% of patients would not return to dialyze in July, due either to death, hospitalization, or moving to another facility not part of the network. So at the end, we were able to obtain close to 28,500 samples spread out through the US, as you can see from this map. And overall, these patients lived in 46 states and in 1,013 counties, and that was about 32% of all counties in the US. So we receive anonymized data from Ascend on patients' age, sex, race, and ethnicity, as well as residence zip code. And then using the remainder plasma from the July samples and the FDA-approved Siemens SARS-CoV2 total antibody assay, Ascend also sent us the total IG results. Note that this, like Julie had mentioned, a Siemens assay is reported to have 100% sensitivity and 99.8% specificity. But in an independent investigation of various assays, the Siemens one was actually reported to be the best at the time of this study. So we also use publicly available data in the analysis. And we start by using the United States Renal Data System to define the population of US adult individuals receiving dialysis as of January 1st, 2017, which was the latest data available that we had. So then we used the 2018 American Community Survey one-year estimates to define the general US population. And linking the patient zip code to the ACS 5-year estimates, we were able to ascertain patient social demographic information, such as the neighborhood proportion living below poverty level, the neighborhood racial and ethnic mix, as well as population density. Finally, we obtain cumulative and daily cases per deaths and deaths per 100,000 at the patient's county level using the Johns Hopkins University Coronavirus Center. However, for the state of Utah and for New York City, we had to use their own specific dashboards as information at the county level was not available in the Johns Hopkins University dashboard. So today we will present prevalence estimates in our sample, but also standardized to the US adult population on dialysis and to the general US adult population. Standardization was done using weights calculated based on 32 strata on regions, age, and sex. We were not able to include race and ethnicity because about 40% of our sample were missing that variable. And so these weights were calculated for the population on dialysis using data from the USRDS, and for the US adult population from using the American Community Survey. The separate weights are then assigned to each person on the sample and used to estimate the prevalence in the respective populations. And so this is just an overall description of the methods. And now I'll turn to Dr. Shuchi Anand, who will summarize the results.
Thank you, Maria. All right, so as Maria mentioned, we had 3 populations in our analysis that we were looking at, and I'm just going to walk you through some of the similarities and differences in their demographics. So for our sample population, in terms of age distribution, about 50% of our sample was 65 years of age or older, which matches the distribution of the US dialysis population almost exactly, but it does not match the distribution of the US adult population, of course, in which 20% of patients are 65 years or older, 20% of residents are 65 years or older. In terms of sex distribution, so in our sample population and in the US dialysis population, we had a slight underrepresentation of women compared to the US adult population. And this is because patients on dialysis are disproportionately men. There's a higher risk for end-stage kidney disease among men. Also, as Maria mentioned, we did look at self-reported race and ethnicity, but we had more missing data in self-reported race and ethnicity, and we used neighborhood or residence composition as a complementary tool. So about 30% of our sample resided in areas where the majority of the neighborhood was composed of people reporting as Caucasians or whites. And that's very similar to the US dialysis population, although in comparison, we had a slight overrepresentation of people living in majority Hispanic areas and a slight underrepresentation of people living in majority Black areas. But compared to the US population overall, we captured more people who were living in majority minority areas. In terms of the regional distribution of our sample, compared with the US dialysis population and with the US adult population, we tended to oversample from the West and slightly underrepresent the Midwest. And that's just because of the distribution of the facilities where we sampled from. So based on the characteristics of this sample and applying the spike protein receptor binding domain antibody assay in July to the 28,503 people that we had sampled, we found a seroprevalence of 8%. And as you can see, the estimate was reasonably precise. When we standardized to the US dialysis population, the estimate was 8.3%. And standardizing to the US adult population, the estimate was 9.3%. We did apply sensitivity ranges based on external validations of the assay that we had used. And even applying the sensitivity ranges and being inclusive of their 95% confidence intervals, we found a seroprevalence estimate of 7.9 to 9.8% for our sample population. So this figure shows seroprevalence by state. And the white states are states that we did not sample from. And the states that are bolded in black lines are states where we had more robust data. And I will say that our sample was meant to provide precise estimates at the regional level. And so on a regional basis, what we showed that the sample prevalence in the Northeast was 27%, 4% in the South, 7% in the Midwest, and 3.5% in the West. We also compared the seroprevalence estimates to reported data on cases per 100,000 and deaths per 100,000, as well as percent testing positive on a state level. And we found that these data correlated best with deaths per 100,000 as were reported in the JHU dashboard. For 3 states in our sample, we had sufficient data to try to drill down on a county level. So we had about 3,000 to 6,000 patients sampled from each of these states of California, Texas, and New York. And you can see that the seroprevalence was widely variable across these states by county. And when we compared this measure to cases per 100,000 or deaths per 100,000, actually there was not significant correlation. There was more heterogeneity in these comparisons. We also evaluated risk factors based on community and neighborhood characteristics. And we found that if a participant lived in a Hispanic neighborhood, his or her odds of seroprevalence were 2-fold higher. If they lived in a majority Hispanic or Black neighborhood, their odds of seroprevalence were 4-fold higher. If our participant lived in a neighborhood where more than 20% of the population was living below the poverty line, again, they had a 2-fold higher odds of seroprevalence. And if they lived in highly population dense areas, their odds of seroprevalence were 10-fold higher. So just summarizing, as of July, we estimated that about 8% of the US dialysis population and about 9% of the US adult population overall had evidence of SARS-CoV-2 exposure. There was a high regional variation. And where people lived was strongly associated with their odds of seroprevalence. So some of the strengths of our analysis are some strengths that Julie and Maria already touched on, in that we surveyed from a sample of population, from an unbiased sample, because this is a population that is coming for routine care, getting monthly lab draws. And it generally can capture organically people that are considered hard to reach in community-based surveys. So we were able to capture older people, people living in majority minority neighborhoods, and people living in poorer areas. We also had sufficient sample size to achieve precise estimates and be able to quantify differences across strata of interest. And we demonstrate, I think this is one of the more important findings, is that we demonstrate proof of principle for a strategy that would be requiring very minimal patient burden and can be employed longitudinally, in that we can survey the same patients over time as well. But I think one of the major points of consideration for our work is whether we can extrapolate estimates from patients on dialysis to the overall US adult population. And I think there are several reasons why our estimates could be an overcount of what's occurring in the US adult population. One, because patients on dialysis don't shelter in place. A vast majority of them have to come to dialysis at least 3 times a week. So they're interfacing with the healthcare system at least 3 times a week. And they are older, they have more comorbidities. And so perhaps on exposure, they have a higher risk of infection. But at the same time, our estimates could be an undercount. And the reasons for that are similar, in that because patients on dialysis have more comorbidities, they're older, they're less likely employed, and they may be more cognizant of their own health status and have fewer social interactions. Also, unfortunately, when patients on dialysis do get SARS-CoV-2, they tend to get sick. They tend to have higher rates of hospitalizations and death. But I do want to say that on the whole, the estimate that we have is likely to be internally consistent if we do survey this population over time. And also that it comported with estimates from the CDC that were published somewhat later from our study, but surveyed about the same time frame. And they comport with international data that Julie already mentioned from Spain and UK, where despite intense outbreaks of SARS-CoV-2 in those countries as well, the seroprevalence in the population was under 10%. So what's next for us is that we are planning on following a subset of the patients who tested negative in July. And we think this will have significant implications for the US adult population over time, because we can follow the same patients longitudinally, as I mentioned, and that will help us estimate seroconversion rates and risk factors for seroconversion. And we're not doing this now, but if we were able to do it, if we were able to do the same study and repeat over time, we would get internally consistent estimates that would allow us to then look at peaks of the epidemic, the people who get affected, and the distribution, the geographic distribution of the peaks as well. We are also following a subset of individuals who, we're following all the individuals who tested positive in July. And this we think will have implications for the population on dialysis as we assess their serologic response to natural infection. And we can go into detail about this later, but or in the discussion, but generally we can also use that data to inform research around vaccine effectiveness. So I just want to end by thanking all the team members that were involved in this effort. This was a really exciting industry and academic partnership that has yielded results that are of public health importance thus far, and we hope more such work is to come. Thank you, everyone, for your attention.
Thank you so much, all of you, for just a brilliantly conceived study. And I must say the kind of attention that it's been getting is very well deserved. I suppose the first question that I might pose, which is asked by one of our attendees, was how can we best use this information to plan our vaccine strategy? In other words, is this helpful to us in thinking about how we begin vaccination of the population?
So I'll take that first question, because we've been talking about this actually. We don't really know the answer to that yet. But there are some models that are just coming out now that really in the last couple of weeks that are advocating for doing sero screening and vaccinating the populations that are negative for antibodies, and saying that that approach may be better than population screening. I think that's only true if you have a fairly high prevalence of positivity. If your prevalence is obviously 1%, it doesn't make any sense to look for that 1% so that you can leave them out. But it does make sense potentially in some high-risk populations. There's also some talk about using, trying to identify which populations antibodies wane. So again, dialysis patients may be a group in whom antibodies wane over time, and the elderly may be people where antibodies wane. And if we can identify those populations, and by looking at background sero-epidemiologic studies, we may identify those who have a weak immune response to primary infection and target them for vaccination. So there are some models that are coming out that are looking at that as a strategy. And we'll have to see as the disease rolls out where we are when the vaccines actually appear.
Wonderful. If none of the other panelists have an addition to that, this study has been a big blow to those who've been, proponents of herd immunity. A place like New York City is far from herd immunity, and I guess their immediate reflex response was, well, this doesn't really reflect the T-cell immunity that might be there even though antibody is not present. Is there any credence to that you can be antibody negative and still have been exposed, and you're waiting for exposure to suddenly mount a robust antibody response? Could we be overlooking such people?
All right, so I'll take that one too. But so it's a great question. So the role of T cell immunity is a really interesting question. I will point out first that vaccines are really mainly designed to give you B cell immunity. That's what they're really targeting for. So at least we're looking at what we're going to probably be seeing with a lot of vaccines. So that's, you know, this is when you want to relate to how vaccines are going to work, these seroepidemiologic studies probably represent that better. There's no question though that T cell immunity is coming more and more as being something that is important for COVID responses. And particularly in groups that can't mount an immune response, can't mount an antibody response. And so we're seeing T cell immunity particularly may be important in the elderly, for example, who are dying of this disease and may do better if they have a better T cell response. So yes, it may be that there is some immunity out there, and there are some studies in animals and in the lab that suggest that people who are antibody negative can have a T cell response, whether it's to cross-reacting antibodies or to this particular infection, and that people who have been exposed can have a T cell response without a B cell response. So there are some data that there may be some immunity, but we have a very low seroprevalence. It's very low. And there's no way that I could possibly imagine that this 9% is going to get you up to the 60 or 70% with T cell immunity that we would need to protect the population.
Thank you. I completely agree, but it's a question that I had to ask. Shuchi, there's a question about why Arizona, given how prevalent the infection was in Arizona, why the seroprevalence seems to be disproportionately low compared to, say, New York City. Do you have an explanation for that?
I think that might have to do with the timing of when we did the work. It was done in July, and a majority, 80% or more of our samples were done in the first 2 weeks of July. And I think the peak in Arizona, likely the infection peak, even came later in July. And so as Julie had shown you, that the antibody response, and we're measuring total antibody here, but even the antibody response generally is not being mounted, at least on average, until 7 days post-infection. So even when we do our comparisons to cases per 100,000 and deaths per 100,000, we are looking at data from June to compare it to our antibody data from July.
So I would have thought that there would be a serious undercounting of prevalence, because my uninformed guess would have been that dialysis patients don't mount robust antibody responses, be it to Pneumovax or other vaccines. So I think this is really, in my opinion, a very startling result that there's a 10% prevalence. And Rich Lafayette asked the question, why are dialysis patients not showing increased rates of seropositivity compared to the general population? In other words, the opposite of what I just said. Because he says they are high-risk patients, they are low socioeconomic status very often in crowded circumstances, and impossible to shelter in place. So the question is, you know, are we underestimating, or should there have been much more prevalence?
Yeah, I think the answer is unknown. I mean, the best answer that I can give to that question is that our estimates match those of the CDC currently. And the CDC is surveying people from commercial labs, people who come for blood work in commercial labs. So they also have, like Julie said, not a perfect sample, but over the similar time frame, we're matching their estimates. So I think the concerns are bidirectional. And so that's potentially why in the end, the estimates are relatively, on the whole, consistent with the general population. But also another point that I would like to make is that even if there is a distance between the US patients on dialysis and the US general population, if we follow this sample, we can still get internally consistent results for understanding the peaks of the epidemic, and also understanding risk factors and seroconversion rates. I don't know if you have anything to add to that, Maria.
I think the only thing I would add is the the fact that I think you have mentioned that if patients do get COVID, they're also more likely to get hospitalized or to die. And so we would not be able to sample them. So we are missing some of those patients that were really, really high risk, that likely had COVID, but we were not able to sample them because they were not there in the month of July, either because of death or hospitalization.
I think what's most exciting to me is the fact that you're continuing the study and your sample was so early in the course of this epidemic. I'd be very curious to hear what is going to happen, but do you have any speculation on what you think you will find in the months of August, September, October, because clearly there's been a dramatic change in some cities in prevalence?
Yeah, I think we will find that the antibody seroconversion rates, are following nicely the case rates in some of the areas that we're surveying from. Yeah, I think that's likely what we will find. But I think what is of interest to us is what Dr. Lafayette brought up is how long will, or what you said also, Dr. Verghese, is how long will the response last in patients on dialysis? Will it be different in duration than in the general population? And it'd be really interesting to do more work to understand the strength and breadth of their response as well.
Julie, I might ask, epidemiology is such a powerful tool, and kudos to all of you for tapping into this source of blood that's so readily available. But it strikes me that every day across this country, thousands or millions of samples of blood are being drawn for all kinds of reasons. I understand the logistical difficulties in accessing those, but is there a way to generate another general sample more reflective of the US population from samples that already are being collected?
That's a great question. And I encourage people to actually go to the CDC dashboard on seroepidemiology. They have a beautiful dashboard, and they have 3 studies that they're doing on a national level. One of them is that 10-city study that I mentioned that's looking at clinical lab samples from 10 cities recurrently. Another one that they just developed and it just came out, they have their first month is August, is all 50 states, looking at clinical labs in all 50 states and looking at samples from across those states. I actually looked at the data yesterday. They have, in some states about 1,000 samples that they've looked at, but it's a lot of sampling that's going on, and they're doing that every 2 weeks. So they have a really nice site that maps it all out. It's lagging behind by a few months, but it's very nice. And then they also have a survey of blood donors that they're doing. Blood donors, of course, are always healthier than other populations, so they're going to underrepresent the real risk in the population. So there are those. There's a group in Emory that is doing finger sticks around the country, and they are sending out kits to have people do finger sticks in a sample around the US that's trying to get to the point of reaching populations that don't access medical care. And we're doing a very similar study in California, sending out blood spot kits around the state of California to try to access populations that may not be coming into the hospitals and clinics. So yes, there's a lot going on in this field that's going to get, I think, better and better granularity about where disease is and what the risk factors for disease are.
Wonderful. One last question. Do you have any reason to think that the methodology of your antibody testing, in that you targeted one particular antigen or one particular receptor site, might have made a difference in the positivity rate? In other words, could a different technique have shown a very different result?
Shuchi, you want me to? I can answer that. I think they would show a different result. Yeah, I do think that you'd see somewhat different result. Not a huge difference. I think the data suggests that they respond fairly similarly, but I think the spike protein, which we didn't look at, has the most stable response, but it also has more cross-reactivity. So it's just a little bit hard to know whether we should have used a different test or not. One thing we might consider going forward, and we've talked about, is at least in our positives to do a second test, because that just gives us far more certainty about the assay, and also will allow us to see waning of specific antibodies. We've been also working with Scott Boyd to talk about looking at neutralizing antibodies and binding inhibitor antibodies so that we could actually get a much broader picture of the various responses over time.
I think we're almost out of time. I just want to compliment all of you. There's been wonderful work that's come out of Stanford, but I think this is singularly one of the most important works because it really, gives us a footing when people loosely talk about herd immunity and make speculations that are not grounded in science. So thank you for doing such a brilliant job and, a great example of cross collaboration with infectious disease, nephrology statistics. Thank you all. Bob, do you have any closing thoughts?
I think you've summarized it well. Abraham, Julie, Shuchi, and Maria, thank you for this terrific presentation. And as Abraham said, it's nice to have some real science to back up one's statements on immunity. So thank you.
Thank you.
And thank you all of you for joining us. And please tune in again next Wednesday. We look forward to a discussion on wildfires and human health. Thank you all very much.